you and the board of supervisors and the support that you have given us. Now let me introduce our guests. First we have, if you look to my right, we have a table that is set up. This will be our panel for tonight. First of all, we have Dr. Dane De Silva. He's the Director of the Division of Population Health Data in the Office of Family Health Services, and he will be providing the information tonight on behalf of the Virginia Cancer Registry. Next, we have Rebecca Thomason, who is the Program Manager of the Environmental Health Public Health Tracking Program within the Division of Population Health Data in the Office of Population and Family Health Services. Next, we have Lance Gregory, making sure I'm in order over here that we set up right. Lance Gregory, who joins us on behalf of the Division of On-Site Water and Wastewater Services. Lance serves as the Division Director within the Office of Environmental Health Services. Next is David Dawson. He's the Engineering Field Director in the Abingdon Field Office with the Office of Drinking Water. Next is Dr. Noelle Bissell. She is with the New River Health District, and she is their director, but she also serves as our medical consultant in both Linwood and Cumberland Plateau. And then we have Stephanie Dunkel. She is representing the Office of our Commissioner. She is the Deputy Commissioner of Population Health and Preparedness out of the Central Office. We have also on this panel that are joining us virtually is Dr. Dwight Flynn. He is with Public Health. He's a public health toxicologist. He's with the Office of Environmental Health. We also have Dr. Amy Hayes, Health Assessor, Office of Environmental Health. We also have Cassandra Gabbard, who is a health educator with the Office of Environmental Health, and Jeffrey Kirsch, who is Regional Director of the Department of Environmental Health. Also, if you look around the room, there are several of us who are wearing red sweatshirts, and that is my team. That is the local, those are our local health department team. That is my team. That I smile when I say that because I'm very proud of them and very thankful for them. And they're an amazing team, and this is part of them, and I'm very thankful for them. Also, we have several guests with us that are sitting in the bleachers, and I will make them all stand, that they have joined us. We have our regional PIO of Scarborough. We have Dr. Megan Hemlick and a member from her team she's the director for Mount Rogers. We have Matt Edinger, who is also with us from Environmental Health. And I just see my other team. I also see Mr. Sally, who is locally Scott County Maintenance Director. And so I appreciate all of them being with us, and they will be on standby if questions present that they need to address as well. So thank you for being here. Sure, I'm not losing my place. Did I miss it? Behind me, do you want to share? I have Paige Borgwine, who is a regional epidemiologist, and she will be monitoring the chat there to get questions virtually. And of course, my team is sitting behind me as well. With those introductions, I think you'll be hearing from several of them later. And at this point, I want to turn it over to Dr. De Silva to do the presentation on the cancer cluster investigation process and report findings. So Dr. De Silva, please.
doesn't end right here. As we walk through this report, we do hope that this will provide answers for how we approach this investigation. So to begin, we'll start with an overview of what the Virginia Cancer Registry is, and then we'll talk through the process for how a suspected cancer cluster is investigated, and then we'll go through the report findings and the recommendations. So starting off with our Virginia Cancer Registry. Our Virginia Cancer Registry is a statewide population-based registry that is state mandated and collects information on individuals diagnosed in Virginia or who are treated in Virginia, as well as those Virginia residents who may have received cancer care out of state. Of course, for our out-of-state registries, for particularly our border counties, they report approximately 5 to 8% of our caseload. And the registry is a partner in statewide activities to help inform cancer prevention, early detection, and successful treatment and care. So why do cancer registry data matter? It helps us to monitor cancer trends. It helps us to identify disparities or differences between populations, whether that's race or age or sex. It helps us to investigate potential cancer clusters. Cancer data also helps to prioritize interventions that may be needed. It will also help to evaluate effectiveness of those interventions for cancer. Cancer data can also be used to help determine whether certain therapies need to be expanded so that the right people access it. And then cancer data also helps to inform healthcare policy, which is also important. But ultimately, we do acknowledge and want to emphasize that our cancer data is important because it does carry the legacy of cancer survivors. We do have reporting requirements for the cancer registry. So in the Code of Virginia and our regulations, we require all facilities, labs, and or physicians who diagnose and or treat all active cancers to be reported. And that is within a 6-month time period as per our regulations. We are an incidence registry only, so what that means is we collect anytime there's a new diagnosis of cancer. And so all active cancer cases that are diagnosed and have their first course of treatment in Virginia are collected. So any sort of follow-up is not collected through our registry. Our registry also does collect death information for all patients. And of course, residents of Virginia treated out of state are reported to us through interstate agreements with other state registries across the country. So to describe that and to provide a little bit of a visual for how all of these data inputs are used and extracted and imported into our database, as I mentioned, we have our reports that come from cancer care providers, from our death certificates, as well as I mentioned, across state registries as well. So all of that information gets fed into our central cancer registry. And then we have certified and trained registry staff that will look at those reports. We often get multiple reports for the same patient, particularly if the patient will get and seek multiple opinions. So our staff needs to consolidate that information, combine that information into one patient. And of course, we go through some quality control steps as well. So cleaning, we do have benchmarks that we have to needs for completeness of different variables within the registry, as well as ensuring that the locality and the residences are appropriately mapped to the right county. And so all of that information does get submitted nationally to what's called a call for data, and we submit those to both the CDC and the North American Association of Central Cancer Registries, or NACER. And those two organizations also do additional verification and quality checks as part of our submission and our data process. Ultimately, after that is completed, then that is when data are available to the public through our complex process, and I know that that does take time, and in line with all other registries and what the national organization set for us, it does take about 2 to 3 years. So no cancer registry in the country ever has really live data, so it really has old data that is 2 years out of date. So a little bit about how we investigate cancer clusters. We do use the Cancer Cluster Investigation Guidelines that were released by the CDC, and those were last updated in 2022 after the passage of Trevor's Law, which updated how unusual patterns of cancer and environmental concerns are reviewed. And that law was a federal law that was passed that had to do also with a pediatric case. And so the CDC came together to update those guidelines to ensure that we are using the most robust and appropriate science. So to define what a cancer cluster is, the CDC defines this as a greater than expected number of the same or etiologically related, which means similarly related by a cause, that occurs within a group of people in a geographic area over a defined period of time. They also included what's called an unusual pattern of cancer, which follows a similar definition here, but it does not have to be within a given geographic area. There are 5 main criteria that the CDC guidelines outline to meet a cancer cluster. So as mentioned as part of that definition, it does have to have a greater than expected number. So does the number of observed cases, is that greater than what we would typically expect in a similar setting? Are cases are the same or etiologically related? So are they in the same family? Do they have a known or suggested exposure that could link multiple cancers together? Are they within a group of people? So defining a population here, that could be defined by demographic factors like race, age, or sex. And then finally, or in a geographic area where it may be based on the zip code, it could be a county or some other boundary here that defines the area of investigation. And then finally, over a period of time. So the time frame used to establish that beginning and end date of the analysis will affect both how we calculate the observed cases and the expected incidence or the rate of cancer in that population. We, of course, on our website do have our cancer cluster inquiry form, which can be found here on our BPH website if we look up cancer cluster, as well as summaries of previous investigation. There are usually 3 main outcomes of cancer cluster investigation. In most cases, an investigation shows that the suspected cluster is not a true cluster. And less often, an investigation may find a true cluster, but no cause can be found. And that's because some cancers can occur simply by chance. But in these situations, it's not because it's due to one specific cause, but rather reflects some spatial grouping among individuals who have been diagnosed with cancer. And then finally, rarely, an investigation may find a cancer cluster where the cause can be determined. And in a scientific review of over 500 cancer cluster investigations done over 20 years, about 1 in 8 have found a true increase in cancer rate, and only 1 case was found. In only 1 was there a clear cause for an increase in that cancer rate. We do have supporting partners that support a cancer cluster investigation. So we do have our environmental public health tracking, and you'll hear from Rebecca Tomlinson shortly. We also collaborate with our public health toxicology, as well as our local health districts to ensure we have all of the information and that we are engaging with the community. So just walking through here the steps here, the first step really is to get the information for an inquiry. So, what are the types of cancers, the number of reports, demographic information, which helps us to also determine whether if something unusual happened happening with respect to those demographic characteristics. Again, the geographic area of concern, the time period, and any environmental exposures. Then the next step we take is that we have our certified cancer data staff that will verify those cases that are reported to the registry. They will match the reported cases to those to our cancer registry to help confirm the diagnoses, as well as the types of cancers that we have to investigate. And that's important because sometimes cancer can spread to other areas, but we need to look at that original site. And then we often obtain additional case information from the registry to help define the population as well. Next, an epidemiologist will help to define that population, geographic area, and type of cancer, and the period of time, and meeting those criteria that the CDC has set before we run our analysis. This helps to just define how to set the investigation, and then we also do pull in any additional cases that are within our registry that may not have necessarily been reported to us. And then next, our cancer epidemiologist will perform a data analysis to determine if the number of cases that we are seeing is statistically higher than expected for this population. And the observed number of cases are typically compared with what you would expect for that geographic area and would include comparing to the locality and or Virginia. This is just a brief overview of the math behind the test we use. So we use what's called the standardized incidence ratio, and what we do is we take the rates at the Virginia level to calculate the expected number using the population of that geographic area, so for example in Scott County, and then we will take what's reported to us in the registry for that area, and then we'll just divide the two to calculate this ratio. And then we also do calculate what's called the confidence interval to really look at that precision of that estimate. And if that confidence interval includes the number 1, which means that there's no difference, then that result is not considered statistically significant, and so an increase or decrease in cancer could be due to chance. Step 5, so if that data analysis suggests a significant increase, a more in-depth investigation would be completed, which could include environmental risk factor assessment or an epidemiological study like a case control. And we would also seek federal assistance from the CDC and or the Agency for Toxic Substances and Disease Registry. When we respond to environmental concerns, CDC guidelines do also include a decision-making criteria. For example, has the environmental concern been raised related to the pattern of cancer in the area of concern? Could there be a plausible explanation for how that exposure could lead to the outcome of cancer? We also look at the scientific literature to look at how those environmental contaminants may play a role in the cancers of concern. And then we also look at that latency period, which is that time from exposure to that outcome, to understand whether or not this is consistent or whether or not it's unusual. So if any of the answers to those criteria is yes, we do refer the concerns to appropriate subject matter experts and or an environmental regulatory agency. However, even if the data don't suggest a cluster, VDH will still respond to environmental concerns with educational information and resources as part of our response. And as mentioned, if the data do suggest a cluster and a common environmental exposure is suspected, VDH would explore an in-depth study like a case control. To date, though, VDH has not identified a cancer cluster that has been caused by environmental factors in the Commonwealth. then finally, we do conclude with a letter of report of the findings. And investigations can always be reopened in the future, especially with the addition of new full-year data. Investigations do have some limitations to them as well, as also outlined by the CDC. For example, if there's a small number of cases, that could affect the statistical reliability. Sometimes too, the latency or that time from exposure to diagnosis could vary by cancer type and could be quite long. We also know that people do move in and out of the area, so when a patient is diagnosed, it may not be the same places where they lived, where they may have been exposed to a cancer-causing agent. Cancer causes also can be, there are multiple reasons that cancer could be developed, and so sometimes it is challenging to also pinpoint exactly what caused someone's cancer. And as mentioned, the cancer registry data from our registry is delayed by 2 years, and that is the norm from across the country. We do use data that is at least 90% complete, and by that I mean we look at Virginia as a whole, and we look at the number of cases we receive and the number of reports, and we look at and calculate an expected number, and based on each year we should meet a 90% threshold after 2 years. And so we do require having that full year data to, be able to calculate that Virginia rate and then compare to the geography that we're looking at. So looking at what we did for our Scott County investigation, we know that a survey was sent out to the community to be able to report cases to us, and then after Analisco provided that information back to us, our staff reviewed each patient's diagnostic summary to again verify that primary instance of the cancer and not to where it spread, to again set the parameters for the analysis. And then even though we had the survey out, we did also pull in additional cases that were in the registry that may not have been in that survey. And then in line with our CDC guidelines, we applied that standardized incidence ratio calculation to each pediatric cancer type. And we did that, we examined all of the cancer types separately, and we could not combine them, which is in line with these criteria for cancer cases to be similarly related. So defining the parameters for this analysis, again, population and geography, being the children 0 to 19 within Scott County, and then we used a 10-year frame of 2014 to 2023, again, acknowledging that cancer registry data are lagged by 2 years. And then the cancer types that were reported in the survey included bone and joints, leukemia, non-Hodgkin's lymphoma, other endocrine cancer, including blindness, testicular, and thyroid. So about the recent cases, we know that the community also has a concern for 2024 and 2025. However, registry data are incomplete for those years, again, in line with other cancer registries. And as that previous visual that I mentioned before is because of the time that reporters report those cases to us, so up to the 6 months, verifying the cases, diagnoses, cleaning, the quality control, ensuring the right residents, and then exchanging as well with other state registries. However, our registry does remain committed to addressing the 2024 and 2025 cases when those data do reach 90% completeness overall in Virginia, which is expected to be for 2024 early this spring, and then for 2025 next spring. So just wanted to walk through some of the survey findings that were reported to us. We had 12 cases that were reported through 2025, and we did have a cutoff for this analysis when the survey ended at the end of July, so it doesn't even capture the full year of 2025, so So we did observe 5 cases that we matched against the registry and fell into the time frame. We did observe 3 cases that were diagnosed in 2024 and matched with registry, but were not included due to incomplete full-year data at the Virginia level. In the survey, there was 1 case that was diagnosed in 2025, but could not be verified due to the reporting lag. We had 3 additional cases that were with different cancer types diagnosed before 2020, but could not be verified and were not included. However, we did observe also that 2 of these reported previous residential histories in and around the bordering state. We did observe as well in terms of the demographics that 75% were male and were diagnosed at 5 years of age or younger. And that's important to note because this aligns with the current understanding that males have a higher incidence of pediatric cancer. So the gender distribution that we observed is not unusual. We did observe 4 that self-reported a general family history of cancer and 2 self-reported positive genetic findings specific to the cancers. So we used that 5 matched cases within that time frame and found 3 more within the registry that were not in the survey, meaning that parameters were geography, timeline, and population. And so we do have those cancer types that I mentioned and the numbers observed during that time. The next few slides will just be looked at just trends over time, starting from 2010. These are just to show kind of the trend over time. So you'll see the black line being Virginia, we have blue being the Leadville Health District, to include Wise, Lee, and Norton, and then we have orange representing Scott County. These are aggregated years for 5 years, and we do that to analyze trends and changes over time. That helps us have a clearer picture of health outcomes and can account for off years like 2020 when the COVID-19 pandemic occurred. Now it's important to note, and I know some of the lines you see are quite high, but a lot of these case counts are low, as we saw in the previous slide. So when you calculate a rate that is based on a very small number, it does fluctuate. The fluctuation is quite pronounced, especially when you're thinking about a smaller geographic area and as the population that you're looking at becomes smaller and smaller. And also, the rates that we look over time, these 5-year rates, you can have that same cancer appear across multiple years here. So, for example, if an individual was diagnosed in 2015, you would see them in this period of 2011 to 2015, you would see them in 2012 to 2016, 2013 to 2017, and so on, because the 2015 year falls within that 5-year period. So, showing through the trends over time here, we do see, and we see Virginia, being a little more stable because of the larger population in Virginia here. So these are bones and joints and testicular, and then we do have like fibroid fluctuation again. But again, some of these are based on small counts. It's important that we don't jump to any conclusions when interpreting some of these lines as well. And then we have other endocrine, including blindness. We have leukemia as well, and then non-Hodgkin's lymphoma. So looking at our calculation that we did, so if you look at the second last column here, which is that SIR test, we calculated that observed divided by the expected, and the expected number right now is rounded up, so we can, because of the small numbers, and so you can see in that confidence interval within the parentheses, they are very wide, and CDC guidelines actually don't recommend using closer when you have such small numbers, but to enhance that and really ensure that we're using the correct test, we also used another statistical test that is really good at detecting differences of small numbers. And what it reveals is a probability value, or p-value, and we use a standard statistical cutoff of 0.05. So all of these p-values are above that cutoff, which suggests for 2014 to 2023, Scott County cancer, pediatric cancer did not differ significantly from those observed statewide. Now we'll turn it over to my colleague Rebecca to talk through the environmental risk factor assessment, as we know that there were some concerns raised by the community as well.
Thank you, Dr. Silva. Again, Rebecca Thompson. I've been helping to coordinate the environmental aspects of this investigation. I know you've covered a lot of slides. I promise we're almost done, so thank you for sticking with us. I'll be going through the steps we took to evaluate if a common environmental exposure may have been playing a role in some of the cancer types that we observed. And I'll also be providing some of the resources that we have available, as I know there have been some environmental concerns over the last couple of months. So one of the first steps we did was work with the Illinois Health District to conduct a literature review to really look at the available studies to see, as Dr. De Silva said, if we could combine any of those cancer types, because we know that different types of cancer are caused by different types of things. As a result of that literature review, we were not able to combine any of the cancer types for further analysis, but that could change in the future, certainly, if the cancers reported change. We also conducted mapping to really help us understand the geographic distribution and help us with really generating any kind of hypothesis that could be related to the environment. And I know other groups have started to map as well. We did not find any unusual pattern when we mapped the cases. In other words, cases didn't really seem to concentrate in any area based on residency location. We cannot release the map, unfortunately. You will not see it in the report. It contains patient addresses, so despite all, we're not able to release that. And we also reviewed several community and media concerns that have been raised over the last couple of months. These were, I would say, very varied, but did mostly relate to drinking water, both private and public water, radon, and industrial sites. So quickly, I'll just go through some of those concerns. We were made aware of some radon concerns among the community. From our literature review, we do know that there is pretty limited, unfortunately, information and non-conclusive evidence regarding childhood cancer and radon. There is some maybe smallest, most association in the literature regarding radon exposure and childhood leukemia, but not necessarily other cancer types. But what we do know is that radon is the second leading cause of lung cancer among adults after many, many years of exposure. Our program, our PDH can receive radon results. They have been reported to PDH for many years now. We know from my EPA map and also test results that have been sent to PDH for many years on radon from homes at Scott County, along with several localities in Southwest and Northwest Virginia, have historically had higher indoor radon results. And so we would say, for this reason, and for also just regardless of any cancer cluster inquiry, we always just recommend test your indoor air in your home for radon. If you're buying a new home, certainly, but about every 2 to 3 years. And I think our radon expert is here too afterwards if people have questions about testing or radon in general. Wanted to mention schools in Virginia are required to test schools for radon. It's a requirement in the Code of Virginia. School results were not reviewed in depth by us, and the reason that we did not review school results is because majority of the cases we reviewed were diagnosed at age 5 or younger, so a school-related hypothesis just didn't seem to make sense at this time to explore further, but certainly that could change in the future. In terms of resources, I believe there are some radar kits. Maybe somebody weigh in on that. If anybody would like some here this evening, which is great. And then there's the information. If you didn't want one tonight and you desire one, we can make sure that you are able to get one. In terms of public water, we are aware that there have been some public water concerns. We did observe a few cases rely on municipal water or public water. Most county residents, and you know all this, I'm sure already, do receive public water, about 3/4 do, through the Scott County Public Service Authority. There are 13 active public community drinking water systems in Scott. Just wanted to kind of just reiterate, these are federally regulated systems. They are required to be tested for up to 80 contaminants on a routine and regular basis. Water is tested a lot, and at this time, all community water systems do comply with state and federal requirements. And if David Dawson is also on our panel, will be available during the Q&A if there are additional public water questions. As part of our assessment, we did observe a few cases which do rely on private drinking water source, not a shared well, but different individual private drinking water wells. So we wanted to just make sure that you all have the resources you need if you do have concerns or questions about the quality of your private well. The main resource that we can recommend, and we can talk more about this during the Q&A, is the Virginia Household Water Quality Program. This is actually a program led by Virginia Tech. It's great. It can provide many resources for homeowners, help guide you in terms of how to test, what to test, and how to interpret the results. Our local health department also has some subject matter expertise regarding private well testing. And Les Gregory, who oversees the Division of On-Site Water and Wastewater Services, is here this evening and can help answer any questions about private water. And his program can also help interpret results. And we would just say, we always encourage any private well owners to test their drinking water if on a well, and this recommendation for VDH really hasn't changed in light of this recommendation. In light of this cancer cluster concern. And just mentioning any private well testing, and we can answer more questions in the QA, but this would be at the discretion of the property owner. And then finally, wanted to go to the industrial site. So we were made aware of just, I would say, more general concerns about industrial sites in the area. We always refer those concerns to our VDH Public Health Toxicology Program, who then in turn met with the Virginia Department of Environmental Quality. They discussed several sites in the area. I'm just going to refer to my notes real fast. Some of the sites that were discussed include Turner Production, Joy Global, Sunbright Foot Mineral Mine, Virginia Hybrid Energy Center, and USB Lady. No environmental concerns related to these facilities were noted by the DEQ. We did, as I mentioned before, we mapped the cases. We also looked to see if there was any pattern that was suggestive of any relation to industrial sites or activity. We did not see that. That was in the initial map of the cases that we had. So at this point, we do not recommend further environmental testing at industrial sites in relation to this investigation. Certainly, if the need arises to review those results in the future, we have subject matter experts on hand at VDH, like our toxicologists, that could help us review those results. And so I would say in general, just based on everything we looked at, there were no clear environmental avenues for further investigation. But as Dr. Priscilla said, we're certainly not walking away. That could change if the pattern of cancer changes or the data changes. I think I'll turn it back to Dr. Priscilla before the Q&A.
All right, so just two more slides here. I know that was a lot of information. In summary, at least for this time, for the 2014 and 2023, our investigation did not find that pediatric cancer rates or the individual cancer types analyzed in Scott County are elevated. And so this does not meet the definition of a cancer cluster for that 10-year period. And so additional epidemiological investigation into a common environmental exposure was not pursued. And a review of literature and the available data did not suggest an environmental link to explore further. We still make some recommendations, and as Rebecca mentioned, it does not end here. We will continue to assess Scott County pediatric cancer cases in 2024 and 2025. And as I mentioned, 2024 data are expected to be 90% complete early this spring. Again, 90% as a whole of Virginia, and so we will update with a preliminary analysis at that time. And VDH will coordinate with state environmental and toxicology experts to monitor any additional concerns, and will engage with federal partners such as the CDC and or the ATSDR as appropriate. And so further epi investigation of environmental exposures will be pursued as appropriate and in alignment with the CDC guidelines for investigating unusual patterns of cancer. VDH also recommends that community members follow typical public health recommendations, even in the absence of the cancer cluster, such as testing your well water and testing your home for radon. And finally, the VDH does not recommend further epidemiological study at this time of environmental exposure based on all of the information reviewed. We do extend sincere thanks to the Scott County community members, local and state elected officials as well for their partnership throughout this investigation process. I know this has been a tough situation, and we do acknowledge that each case included in this review does represent a well-loved and cherished member of the Scott County community. And we do encourage the community to reach out to the Scott Cancer info at vdh.virginia.gov for any other questions, or if you would like to continue to submit information to the survey. Thank you.
Thank you, Dr. Basillo. We're going to entertain questions at this point, and so there's two approaches to that. I know we have several people online that will be that will address their questions in just a bit. Page Board White is monitoring that. We'll take those at the end. But what we're going to do, if you picked up an index card and you wrote your question down because you don't want to read it out, or you're not comfortable coming up to the microphone to ask us a question, if you'll raise your hand, one of my team members will collect that card from you and bring that question up to us, and we'll take that question at this point. If you would like to ask us a question and you're comfortable, we have microphones on each side of the room. And I have this. I'm sorry, I stole this microphone. So the microphone is on this side of the room. If you will line up, you can come to that microphone, and you're welcome to ask us a question, and we'll do our best to answer that question with the panel. So we'll entertain that at this point. So anyone that would like to ask a question, you're welcome to come to the microphone.
I think, my name is David, I'm from the city. As I looked at the data there, the decision to not to combine the cases seemed like a really important conclusion or definite to me. Of the 8 cases, 6 of them were put in their own bucket, right? And then the minimum expected number of cases was 1. So right off the bat, 6 of the 8 cases were going to be concluded not to be a problem. And so my question is, did you guys look at what would the answer have been if they were combined? And, essentially, let's discover, do we have a problem here in total? What would that be?
Thank you for your question. So in line with our CDC guidelines, we do have to investigate each cancer individually because each of the cancers do have different exposure types and different risk factors. And we did try to look at our literature to also see whether or not we can combine those. And based here, we did not combine them, so we did not look at them as a whole, as an aggregate. Yeah, so I guess what I'm asking though is, can you give us an answer on what the answer would have been? Because it seems like that's a really important decision not to combine, and I'm trying to just understand how to work with that decision. Like, if you said, even if we did combine, it's still not a problem, I think about that a lot differently than if we combine, we're in the, 1% outlier range. So I'm just trying to understand, like, how critical was that? Yeah, so again, this is part of the CDC investigation, and the CDC guidelines recommend just looking at them individually unless there are exposures that can combine them, and then in that case we would combine them. So in this case, because we did not observe anything, we did not do that calculation as together.
Good evening. My name is Jennifer Jenkins, and I have a few questions. I have heard that you guys talked about radon and water. What about air quality in this area? Was that tested?
We did not explore any air quality results as part of this investigation. One of the things that we were looking for through actually the survey that the Louisiana Health District put out was any really common type of exposures that would have showed up and through the information that was collected, and we did not find that was kind of an avenue to explore further. But to answer your question, we didn't specifically review any air quality results of the area, and I hope that answered your question. But certainly, if again, if the data were to change in the future, if there was a kind of unusual pattern that was suggested, that was suggestive of some kind of exposure to a contaminant through air or through inhalation, then that is something that we would explore, I'm sure. We just haven't done it this time. Is anyone else?
Was the radon or water quality tested in these specific children that have cancer? Did you see high results or not?
Thank you for the question. I'll answer on behalf of the water quality. As was mentioned, so there's many tests that I mentioned. A lot of tests for over 88 contaminants that are done on a daily basis or more for all of the drinking water. The public water system, 3/4 of the people in Scott County receive their water from the public system or otherwise translated to get a water bill on that. And so those are all within compliance. So that was, we don't have, there isn't data for the 25% of those that are on private wells and on springs. And as mentioned, there were a couple of cases there. But so all of those were in compliance with the drinking water. And one thing on that I would say is, well, maybe that's not, what was the other one that was on
Radon. Did you test the radon at these children's homes or grandparents' homes that they're all daycare or whatever? To know specifically what those specific children with cancers levels are?
Thank you for the question. I think that is a really good question because I know that I mentioned some radon results in the slide, and what I was referring to are test results that have been shared with VEH voluntarily for many, many years from the testers. But we did not specifically review radon test results from the cases.
Because of this, we have a radon test online for our home, and in the last 30 days, it has been
We have connected with Tennessee colleagues as well. We have not heard anything. They have not heard anything from their end. We do have to, as part of the investigation, do have to define the geographic boundaries of it as well. So it does get harder when it crosses state boundaries with the registry. And so because of that, we don't have necessarily the Tennessee case residents in our database. So based on the survey findings, and the survey that was put out by the Minnesota Health District, we defined the geographic boundaries to stop it.
I want to just add a little bit. We, just yesterday, we hosted a provider call, so clinicians that included Virginia and Tennessee clinicians, so we talked about health. And we shared with them this information, and we talked about it, we answered questions. And so I want to share that with you, that we're in contact also with providers, because we know that they need to get care on both sides of the border. That doesn't stop. So in addition to working with our Tennessee public health colleagues, that call did happen and that door is open and continues to be open with those providers. So if they see anything or anything, that communication line is happening.
And then, one more other little thing that's been a big thing. Have you tested for sewage sludge at farms in local areas? That PFAs in the
We did not review any of those results. I do think we have a representative from the Department of Environmental Quality on virtually. I don't know if he's able to answer that question or weigh in. We might have to get back to you to see if he's able to hear it. Did you want to ask your other question?
Sure.
Answer? Okay. Thank you.
I personally would like to request we test the air quality in this area. That's a huge factor. I think, even just this evening when we were standing outside waiting, I noticed that the sunset was very hazy. There was no fog or anything today. Also, I noticed that the weather pattern in this area, especially where Scott County, when it snows, you never get snow. It snows all around us, but not in this area. I don't know if anyone else has ever noticed that. I'm going to say the word, Eastman. I would like you to look into the air quality because of Eastman being right over the border. I did some research on Eastman, and they have a company in Longview, Texas. If you look at Longview, Texas Eastman, there's report after report after report about the air quality, cancers. They are actually building a $36 million cancer center in Longview, Texas right now because of the cancer rates in that area. That's something to think about. And if this isn't a cancer cluster for our futures, for all of us, I mean, it's a very high possibility, and I highly recommend that you test the air quality and, let us know what that comes up to be. Thank you.
Thank you. We need to try to limit the questions if we can to one per person, because I think we have a few, that's what they're telling me from all one that we'll have to address too, is in parts. So if we can limit those to one per person and then go from there.
Well, my general question is, I'm a professional statistician, and I have a lot of concerns just backing out based on what I can see in this report. And you can't do much, you can scalability, etc. But just the SIR, you can back out. The answer to this gentleman's question. And the answer is yes. If you combine them, there is statistical significance at alpha of 0.05. So if you combine the buckets, there will definitely be significance, which is explained why we're not getting that answer. I could literally use questions, but my simple question is, would you be willing to share your cell counts? Observed, yes. Observed, no. Expected, yes. Expected, no. And I can conduct a very quick Fisher's exact test based on that. The SIR is low power, doesn't really help much, but
rules. We
What
did
about the
do-
state?
Sorry.
What about the expect? That's the entire state of Virginia. It's more than 16.
That request could be made to the epidemiology team for the expected case in Virginia.
Okay, so they gave you Virginia, and whoever had the local stuff to be willing to give you that, I can put the two halves together and that's very easy. I want to ask one more question. Do we use age adjusted for the expected?
Yes, we did do age consent.
And did we do incidence rates or it all count for expected admissions? That makes it a p-value. If you do 5 per 100,000 versus per 2 million, which is what the 0 to 19 population is in Virginia, it doesn't make a difference.
We did use incidence rates
Which would make the count higher, correct?
we'll have to go back to.
It would, I think I'm not going to use incidence rates as less precise. So it's considered a small sample size. If you do 100,000 versus per 2 million.
Right.
It seems as though at every single juncture, a decision could be made to omit something, or maybe to include back that's old and doesn't really add that many cases. For instance, the most recent study they did was only 5 years. It was elevating health district. They used a 5-year sample period, not 10 years. Well, before that, they used 10. So they're not always consistent with the periods they use. But my point is, every single juncture, we made this decision to bias in favor of not finding something. And I know this for a fact. I was astounded when I read the report yesterday. It is amazing. So I would like your part, the amount of my cell counts, at least, and I can do our part with Scott County, some people are comfortable with that. And I guarantee you the results will be quite different. I don't guarantee, but I can say with statistical significance that it will be quite different. So, anyway.
I have a question. So I've actually been working with Trevor Shaker from Trevor's Correct, Trevor's Law. I need to know what can we do to fix these 2 to 3 year delays? Because at this point, our community, we don't have 2 to 3 years to wait on your all's decision whether to cancel those. And I understand y'all have policies and procedures and CDC guidelines and all of that. All of it, I understand that. But what can we do? What can we get rolling to try to get these delays, these data lags fixed? As a community, it's 2026, and we should be able to, get data where it needs to go at least within 3 to 6 months. A couple of years is, if everybody was still on paper chart, I could understand it, but we're not. Especially us here, we're in medical monopoly, and it is the main computer system. And I understand, the state of Tennessee might be a little further behind than the state of Virginia in their data lag, but still, do you all have any insight on how we can get the ball rolling? I've actually been in contact with Trevor quite a bit about this, and we're trying to actually get his foundation and his organization down here to Scott County. Nothing against you guys or anything, but you all have to work with what data you can have, and Trevor's organization and use the data that we collect as a community, and he can bring his own people in and go from there. Because like I said, we don't have 2 to 3 more years to wait to see if the state classifies it as a cancer cluster.
Thank you for the question. Just want to acknowledge, there are different data sources too that have very different data lags. Unfortunately, cancer registry data is one of the ones with the longer ones compared with other hospitalizations or even our vital records data. But again, because of the time for the reporting and when there are multiple cases coming from different facilities and having to consolidate that also adds to the time. And
That's still open. Registry's still open.
Okay, anytime anybody tried to click on it, it wouldn't allow anybody to input information, it just said the survey is complete.
We will check that.
Okay, all right.
Thank you for bringing this up. Thank you.
Hello, my name is Lisa. I want to thank you all for coming out tonight and sharing the information and the research you have done and the work that you're doing to look at our community. I appreciate it. I'm a mother of a 4-month-old. So, and we live in Webersley, so I'm also a librarian, so I can analytical mind, but it's my heart, and I'm sure many people in this room and online feel the same way. I wanted to ask you about the timeline. So, Rob, you mentioned that in the spring, the 2024, 90% of the data should be completed with review. What's the timeline then for the review for the cluster? And as was mentioned previously, there has been an uptick in cases that you're aware of, anecdotally aware of. So timeline for the next identification of whether or not we are in a cancer cluster here. And then what does that mean? If you could speak to, if we are then identified as a cancer cluster, does that mean increased funding? Does that mean support for the families? Does that mean more research? Because again, you mentioned the majority of cases being under 5, which is a chilling data point. So, like the previous person said, it seems like this timeline, we need to find a way to shorten it in any way possible, knowing that we need to do thorough research as well. But just what does that look like, and when can I sleep at night again without worrying about my baby?
Thank you for the question. So we do plan to look at 2024 data this spring. We will, which is when we will be 90% complete. We will also be having 2024 data 95% complete by the end of the year, so we can also do another check then. And then in next spring as well, we'll have 2025 data 95 about 90% complete, so we can do another preliminary check there. And then by the end of the year, but we'll keep doing these checks and using the CDC guidelines to investigate. And so if the data and the results do change, then that would allow us to look at to see whether or not additional environmental testing in line with the guidelines would occur. So we would look at the exposures and of the cancer type that may be elevated to do more testing in that case to ensure that we're also looking at whether or not there's an active exposure for that specific cancer type. So we will be looking at more of that information, connecting with the CDC colleagues and putting in other federal partners as well as moving forward, depending on what the findings will show.
Is there a reason why it requires that first step of being identified as a cancer cluster? Because I think, again, it seems like anecdotally there is this rapid increase happening. Why can't there be those research funds allocated now to start looking at that, to preemptively kind of start addressing those concerns? And I understand that we're a big state, but I think I'm from here, so I'm aware of here. You all have a bigger picture of the state as a whole, but it seems like we are spiking here in Southwest Virginia. I'm not sure if there are other areas of the state experiencing the same level of increase. And so if we are seeing this per capita increase that is, friendly fighting, it's emotion. Why is it that we can't just preemptively start doing some of that research with the understanding that we're seeing this? And I'll stop there now. Thank you.
Thank you. Cancer data, the registry data is the first line to look at when we have a cancer cluster concern, which is how cancer cluster are investigated, and as the CDC recommends. The other thing that I will mention to you as well is like, with each year, with the rolling years, we have about 2/3 that consistently are maybe above the average of the counties in the next quarter, that would be under. So, and that fluctuates like over time. And again, like, with every year, there are fluctuations that just occur also in the chance that alone. So again, that's why it's so important when we're doing an extra investigation to ensure that we're looking for the right parameters, the boundaries, and all of the exposures and everything to really try to get this big picture to really investigate what's going on.
Just wanted to add to that, if at any point we were to see an unusual pattern in cancer or suspect a common environmental exposure, we would request better assistance in the area.
One thing I want to thank you for your question and to say that it is an emotional, and cancer is awful. Pediatric cancer is terrible. Virginia Department of Health mission is to protect the health and promote the well-being of all people in Virginia, and that's what we're doing. There's a lot of technical things, but it is scary, and it's an individual thing, and especially with one's children. And again, it was mentioned, one watches lymphoma, somebody under 5, leukemia. I'll just share, I'm a survivor of stage 4 of both of those, by the grace of God, and also some wonderful medical care. So it's frightening, and then this idea. So we work with the data, and we share the data, we're data-driven, but we do all the people you see in all those in red scriptures very much care for the people here are working on that. And we appreciate the questions, we appreciate the input that folks are sharing, saying, what can be done? But I just want to know that we do appreciate what you shared, and also it's scary, and as a parent.
Hi there, I'm Stacy. I have 5 children in the school system, 2 here, and 3 across the street at Shoemaker. So I was just curious in regards to you saying that Virginia mandates schools have radon testing. Do you all provide the parents here? We want to look for less than 6 months. Also, the test are 6, by the way. I just get that address. We're highly recommend checking that. I do think it's kind of sad that just when this community comes up across the board as high radon testing, but people who lived here for years not even aware that this is an issue. So I would maybe suggest making that public. That's pretty scary. So my question is, since you do testing in the schools, are schools in this community testing for radon? And if they are you addressing it with mitigation or?
I'd like to turn that question over to Matt Edinger, if you're comfortable taking that.
Sorry. My name is Matt. I'm the director of the Office of Radiological Health for the Department of Health. So the answer is we do not test for radon. The Department of Health doesn't, but we require in Code of Virginia that all schools do test for radon. The testing is actually done by the school system. It's either done by officials of the school or by hiring a radon professional to test it. The results of radon testing are sent to our required to be sent to the Department of Health. And we maintain a repository of those, but they're also maintained by requirement by the school system. So yes, the testing is done, but it's not done by our organization.
Yes, thank you. My question is that are you able to tell us, are the schools our children are in, are they testing for above 6, which is high? Are they testing for high levels of radon, or they have something to address it?
So I'm going to turn that over to the representative from the school because I don't want to speak to their records because I'm not the custodian of this record.
presenting with the sophomore schools as a medical supervisor, and testing in all the schools has been completed just as it is part of the code. We have, as we test those, we are also required to report that. We do report all of those numbers, and then also any schools, we will actually have published those numbers, and also any areas that have been high, we do mitigation in the schools, and there's numerous ways of mitigation as far as in schools. And that is something that we have done and we currently do at this time also.
I do apologize, I don't know if you answered my question. I just want to know, is this school where two of my children come? Does it test high for radon? Yes or no? And if so, is there a mitigation system in the school? What's the level of that?
No, it's not mitigation in the school.
Did it test higher?
Excuse me?
Do the levels of radon test high here for Gate City Middle School?
No,
Is there somewhere where the parents are able to view those levels of radon in the schools our children are at 8 hours plus a day? Or
they're available. We can probably get you a copy of that to the school board office. You can reach out to the school board office and we can make it available for that.
I'm just a little confused because I understand why I can't be told that there is radon in the building and that it's being taken care of.
If you're asking that for Dixie Middle School, in the beginning, when we tested, yes, there was a high level detected in one room, and through mitigation and mitigation efforts, that number was lowered below the 14 periods.
Below the level.
It was lowered below the 14 periods, which is great.
So if we wish to do that, we can get that from the Virginia Department of the School System to review those levels ourselves.
We have, did you ask, I'm sorry.
Are we, that's okay. I was saying, is there a way, again, that where you said we can go to the Virginia school system and request one of those levels ourselves, or? I just think if the schools or children are testing for radon, I think the parents should be aware of that, is what I'm saying.
Yes, those numbers are available to the public, so if you would like to get a copy of those, the best place for anyone to get a copy of those would be at the Scott County School Board office, which is at 31 East Jackson Street.
Thank you, sir. I'm so sorry, I know you said only one question, but I'll let you guys. The other two mothers, three, I guess, behind me, the concern is the reason why we're all here is my understanding that most of these children have had cancer in the last 2 years. So their findings only come to 2023, I'm not really sure how that helps us protect our families. I personally just lost my father to cancer. He did live into the seal. Let me point that out. But from the date that we found out his cancer stage, we lost him was 3 months. And you're telling us that we have 3 to 4 months before we get the numbers for 2024 to 2025. And as a mother, that's terrifying. So in 3 months, the cases could double. We have no idea because you don't even have the numbers to give us for the last 2 years. So that is all. Thank you very much.
Just a quick point on radon that might be helpful. We absolutely recommend testing for radon. We can help deviation, help interpret any results, but we did not observe any lung cancer in the cohort that we analyzed, and for radon, that is the main risk. Really in adults, not children, but adults, for adults who have many, many years of exposure to radon at very high doses. So I just wanted to reiterate that yes, we support the radon testing, but not necessarily because of this investigation. I hope that makes sense. And Matt mentioned.
And just a moment before we take your next question, we do have radon kits available at the health department in Gate City, Scott County Health Department. We have some radon kits available that are free. If you would like one, please just stop by and we'll make that accessible to you. As a matter of fact, I think they brought some additional radon kits down. I see Matt shaking his head over there. So we have additional kits that are brought down today for Christmas to add to what we already had. So we do have free radon kits available main city office here across the street. So if anyone would like a free radon test kit, please just stop by our office and we will give you a free radon test kit. So I just wanted to, I think that was mentioned earlier as well. I wanted to, while it was on my mind before I forgot it, with everything else, share that information with you. And if additional kits are needed after that, we're going to have free radon test kits.
I think it's also really important to point out that we have developed a bilateral relationship with St. Jude Children's Hospital, which is where I know a lot of people go and seek care for the cancer. The Red Cap will be kept open. We will be diligent about following up and getting records and being in contact with those providers as far as when the diagnoses are made. You know, unfortunately, there is a lag in data for comparisons, but we certainly can do a lot of that front-end work as soon as we are made aware of this. And we were just made aware in the past several months. And I understand that there is a lot of concern about very recent cases, and we are doing the best we can to catch up and collect that data. So we'll make sure that Red Cap is open, and we have already started conversations with all of the providers in the area who are providing care to get records, to get information, to get diagnoses. So we hear you. We hear you. It is a concern. And to the gentleman in this bleachers, you can't just lump them all together with cancer. That's comparing apples and oranges. And we really cannot do that because that's not how, when you calculate expected cancer cases, and unfortunately cancer happens in every age group, unfortunately. When you calculate expected cancer cases, you can't in Scott County say cancer, but everywhere else in Virginia and the country, we're specifically saying this type of cancer, that type of cancer. We have to follow those guidelines. And if they are similar cancers, if they are cancers that are blood-related, leukemias, there are several different types of leukemias. We can look at those. But to compare a leukemia with something of the heart or something of the kidneys, we can't do that because then it's just not valuable information and it's not valid data. So we really do have to keep them separate and only compare the ones that are similar by system or type.
I want to thank you guys for taking the questions. I appreciate all the information and a very thorough explanation of how the statistics and the numbers work. My question, and I know this is more rhetorical, but is it not fair to say that we have no idea what causes a lot of cancers?
That's absolutely true. And I think anybody you talk to is going to say that most cancers are multifactorial, meaning that there's probably a component of genetics, there's a component of behavior, and there's a component of environment. So that's why determining a cancer cluster is extremely difficult, because it's really hard to control for all those variables.
So with that in mind, the artificial boundaries that we're creating make that information even more complex and confusing. So I realize that the state of Virginia has to do the state of Virginia, and the state of Tennessee has to do the state of Tennessee, and that a cancer of the endocrine system is going to be different than cancer of maybe the kidneys. But when we don't know causes, and we create artificial boundaries with that data, it makes things less accurate to the people that you are discussing, because these individuals aren't just a statistic or a type of cancer or an environment that they're in. These are yours and our relatives and loved ones, and sometimes those buckets that you statistically think creates clarity may be overlooking somebody and not researching what's going on in the individual's household. What is their radon level? What is their water? It's a really big oversight, because we should be looking at the individual as much as the statistic or look at radon levels, how to test for it, how to do all of those things. It's not that they're discarding. In fact, they've been in touch with Tennessee. You recognize that cancer or nothing follows district, county border, state border. Dr. Silva and his team have been in touch with Tennessee. We're in touch with the providers that see both Virginia and Tennessee residents. We just have to separate the cancers by type. We can't just say cancer.
I understand from a statistical standpoint why there are the buckets. I'm just saying, we also know that we don't know what causes a majority of cancers. So if we have everything separated and that's the only avenue that we're looking at, we are going to miss things. So there is benefit to looking at the group. And I would highly recommend, whether it's through this avenue or another, that Scott County looks at the group.
I appreciate that statement, and I just also want to reiterate to you that we would not be following CDC guidelines if we were to be combining different types, just because there may be different causes for the development of cancer. But as we start to review more recent cases and we see that there is potential to combine cancer types based on that etiologically or related part of the criteria, then we will absolutely do so for the recent cases. It's just that during the time period we investigated, we were unable to combine them.
So Robert already pointed out the Tennessee and Virginia border. I just wanted to ask the question is, whenever you all start investigating this in other years, are you going to consider like kids that live in Tennessee that come to Stock County schools, for example? So let's say they live in Tennessee, just minutes away from where we're at now, and they come to Stock County schools, grandparents live in Stock County, all their family lives in Stock County, but they're the only ones that live in Tennessee. Let's say they test positive for cancer, and then they also go to schools over here. So would that be considered in your all's testing, even though they're technically a Tennessee resident? However, all of their time is spent in Stock County, Virginia. Because we live so close to these lines, and that's a critical point, that we are living minutes away from Tennessee versus Virginia. So even in the last 10 years that you all just completed, did you all include or even investigate, were these kids living in Tennessee and tested positive, and they weren't in your all's data because they technically have a Tennessee address, and then they're actually basically living in the Virginia area, and that's where they're at in sports, in scholarships, in, just education-wise, they're living here, but they live right across the border. So my question, when we're talking about the state lines, is that included in your own data?
So, because of each state having their registry, residents would be reported to their own state's registry. But if a concern were brought up by the Tennessee side as well, then there would be a potential to explore across state county lines. But in our connection with our Tennessee registry and also the surrounding area, they have not heard any concerns from the bordering areas. But to answer your question, if the concern were brought up to the Tennessee, then we would move each other around for the shared border area.
Okay, so your answer is yes, that you all would collaborate with each other and you all can combine your data, is that correct?
I have to go back into it because we have different registries, so we can't really share each state-specific one. There are potential, but we have to go back to ensure the guidelines that can be feasible.
And we can and will, and this is, there's some relationship pieces, right, and states to assure that we're talking the same talk, right? But I would say that
use the red cap and explain that a little bit and I'd like to know, we'd like to understand that, right? So we won't know that based on what we have in our data. But if you can share that, if you have kids that are more, maybe not permanently addressed here in Virginia and South County, that would be great to understand and a little bit of that context. We're limited on that information on our end. So I would encourage you to put that, add that to the red cap and keep in touch with the so health department.
And that's a lot of people in our area, and a lot of people travel from Tennessee to Virginia, or across Virginia to Tennessee. So I think that's something critical that you all need to be aware of, because that's a big component in this.
And to add to what Stephanie said, and Dr. Bissell, thank you both for reminding us of that. That was one of the reasons why we collaborated with physicians and had a meeting. We had some meetings this week, I think yesterday, that we have collaborated with physicians, and many of those physicians were in Tennessee. I think the bulk of them. Behind me, can probably not their names.
I think there were on the seat care, Virginia District Seat Care, we are being sent to the Knoxville, which is in Dawson City, and that's where the St. Peter Village are located.
St. Peter's, St. Ballard. We had multiple physicians on the call, and we're collaborating with them for that reason. And so we appreciate you bringing that, and so share that out with us as we, that's important.
Right. Sorry, I have a few questions here. I just wanted to collaborate to set that up before me. The big thing here that I want to know is, are you all going to close this investigation, or is it going to be an ongoing investigation? In my recommendation, that's really important.
Yeah, so one of our recommendations is that we will continue, particularly for the 2024 and 2025 cases. And of course, Stephanie and others have mentioned, we do encourage using the survey to raise any of those things.
Okay. The only thing that us like talking parents are, we just ask for transparency. That's a big thing. These are our kids, this is our kids, so we just want everybody to be open and transparent, so we're asking that of you all. So we appreciate you continuing to investigate. The transparency of it is going to be key here, because these are our kids. These are our kids that are in school. These are kids that are sick, and that's important. And you just don't understand these adults are sick, we get it. It's years and years and years of exposures. But these are kids that are hot, and I think that this lady right now, I'm sorry, I can't remember her name, but you were saying about these radar tests, it's 5 and younger. The 5 and younger is school age kids. These kids are 5 grade girls in school. Those are either pre-K programs or kindergarten. So I think that's something really to, put a stop to that, because these kids are 5 and under. These kids only have 5 years of exposures, and they have positive cancer tests. So that's something significant to think about. And I'm saying this because I've seen a lot of things on, social media being posted, and it's saying, oh, thank goodness that there's no cancer cluster posted, and it was negative, for example. And I just want parents and families to understand that this was considered a negative cancer cluster for now, and I want that to be very evident here, because, they were not able to use these horrible 2024 and 2025 results, and I understand that some of them are different types of cancers, and I know these will be investigated in this coming, springs, but I just want families to understand that this one can still be taken seriously, even though this was not considered a cancer cluster for now, and I want that to be known is for now. And my next question was about the radon. You said that you have been given results for that. Did you all actually come and test the water yourself? Did you test the radon yourself? Did you test our soil yourselves? Or were people in our area giving you that information? So that's my question. Did you all actually come here and check it yourselves? Or was people in our area giving you all that information?
Thank you for the question.
So, a couple of things. We talked about earlier, I think that there's a misnomer, right? So radon is a fickle gas. It differs from room to room in homes, it differs from room to room in schools. So when we talk about radon testing, we're doing rooms, right? So the law in Virginia is for schools, all ground level contact classrooms have to be tested. The reason for that is radon is lighter than air. So if you go up, the levels go down. In a home, we recommend testing the lowest inhabitable level of the home, where you could live, right? If you have a basement, whatever, the lowest part you can live in, and the room you spend the most time in. Because for anything radiation, it's time, distance, and shielding, right? So time, the amount of time we're exposed, plays into that. I just want to clear that up. There's no like radon indicator. You can't put a monitor outside. That's what we're doing. As far as how we get results for the counties, it's, as Rebecca said, it's voluntary. So we can get it from professional testers who voluntarily report their data to us. There are 3 major test kit providers. We send it to them and ask them to give us all the Virginia data. Again, it's voluntary, so we don't know. We assume we get everything, but there's no way for us to know that for sure. And then the test kits that you buy from us, I couldn't see the slides. I think it was whatever, there's an offer. You can go to our website and get test kits for a discounted price, or the free ones that we bought for the same thing. Those get reported to us because that's an agreement with the lab that they come to be with buy. But again, it's all voluntary, so I will say that testing in rural areas is not nearly as, there's not nearly as much of it as in urban areas, right? It's less sparsely population, etc. So the data that we have is as good as what we get. But,
So my question specifically is, did your all's team, anybody on your all's team specifically come down here and get it? Or was it just the people, around that area?
so, like I
And
said,
everyone's asking about Maryland specifically, and they're just like, I'm less concerned about Maryland, more concerned about soil and water in our area. So did someone come down and come to the Scott County Water Department and test that water? Did someone come to our soil and agriculture, and did they test it? Or was that given to you all? That's really my question.
Thank you. So with regards to the private wells and private water wells, we don't have any testing program with the Department of Health, so we simply do a construction permit, and once that well is put into operation, any ongoing testing is done at the discretion of the property owner. And they can voluntarily submit reports to us at any time you help them assess that.
So you're saying if we test our water, we can send it into law and say, like, we're going to get to Virginia, or wherever to Virginia, and you all would use that data, is that correct?
We would be happy to talk with the homeowner and explain those results. And one thing that I wanted to share, so when we talk about testing prior wells, so Office of Drinking Water, we talked about earlier, we're testing 80 different constituents. So those tests, they have cost and can be substantial. And so one thing that, if you have a concern about your private well, or if you have a spring, I would recommend reaching out to us and the football department to get maybe some guidance, because you don't want to just test for everything under the kitchen sink. Get that would be really expensive. And whether it's a spring or a shallow bore well versus a deep drill well, it's going to change what maybe the most concerning constituents you want to test for. And that's where Rebecca mentioned earlier, the Virginia Household Water Quality Program is a really great resource because they do a very low-cost test for a very broad range of constituents. So, I just wanted to throw that out there. I would certainly recommend reaching out to them and seeing if they can kind of do a planning or something like that in Scott County. Just because from a cost perspective, it's going to be really helpful for homeowners that are concerned on their property.
Right, yeah, and that's a big thing that we're getting is, we are very low income families here, and it's very hard for us to even get one, and that's why, we're hoping that you all come in and help us in that aspect, because we, a lot of families who don't have that extra cash on the line, we're able to test their, SIM card for PFAS for those, rare chemicals
with the waterworks, to go accompany them and sample at the same time and compare the results, as well as we go out and inspect facilities on the timelines that are mandated by EPA, so we go to the water system. If you take the different constituents like lead and copper, those are actually sampled at the house. And so there's a rigorous process for that, which is on for the many of your other samples, your microbials, and we check the chlorine residual disinfection. That's how the system, that's been determined by what is the most difficult place to reach, or what would be the most likely place that we would see a result. We see that also for disinfection byproducts. And I mentioned between the life expectancy of somebody in the U.S. in 1900 was 48 years. In 2000, it's 76. And so the advances in health, and we like to think that the disinfection of drinking water played a part in that 60% increase in life expectancy over the 20th century. One aspect is in the 1980s, it's like a little chlorine, a little bad stuff, let's put it on, and then we realize, well, there may be some byproducts from that. And so that's one of the concerns that we track, and that's what I mentioned before, the 280 test results for the trimethanes and the halosate gases, the regulated byproducts from the disinfection product. There was one of the 280 in the last 5 years in Scott County that exceeded the limits. So we do go out, we do sample, and everyone that samples that, in addition to collecting the sample, they have to write the time down, what was the temperature, what was the pH, and then a sample custody, because something could sit for a while, and then it could go bad. And so, and then some folks have sent off, it sent results that labs did not certify, and so is the result, what does it mean? So this is to assure you that we in fact do go out and ensure that the data are accurate, and then the data are from the system as well as from the production point, whether it's the Tennessee City water plant or Moccasin Gap water plant. And there's actually the folks that get served water, it comes from a number of sources. Duffield, from the North Fork of the Clinch. Some of the folks at some of the subdivisions are getting water from Bloomingdale Utility District and City of Kingsburg. They're in the Cove Creek area. Their water comes from the Middle Fork of the Postal River in Washington County. And I'm trying to think where the water from Woozy Creek is, but it's the Woozy Creek Waterworks, and I'm told that that's where the moonshiners used to dump. When the federal revenues came, they dumped it in some communities called Woozy Creek, and so we say, well, the water's good in Woozy Creek.
Thank you. Looks like we have about 10 minutes left to take more questions from the audience, and then I think we have a couple questions online.
Hi, thank you so much for being here, everybody. I have a question. You say that the rates in Scott County are similar to the rates statewide for Virginia. Is that, in fact, an average of all the rates for the whole state? Or how do we compare to other counties specifically? Like if Scott County's rates are higher and then there's a big swath of Virginia where the rates are lower, that average wouldn't tell us what we need to know. And could we see what the rates are for Scott, Lee, and Wise County, and look at, do we have something regionally that is higher than other regions in the state or other counties in the state?
Yeah, so when we looked at the rates, it was at that 10-year period, so we're looking at that 10-year period, and then we are also looking at the 10-year period in Virginia. Now, when we do our usual surveillance, we are using a 5-year period to look at trends over time. And so, we do have counties that do fluctuate. They might not be above average one year and below average another year. Again, that's just part of the variation as well. But we do, use our surveillance and look at that through with our counties as well as our health districts. A lot of the times, though, when we do when we see it publicly, We don't have all of that information available because cancer rates actually should be suppressed when they're based on counts less than 16. So oftentimes you won't, especially when you're looking at a smaller population or smaller case counts, they are quite unstable to really interpret and make meaning out of it. So you know, it takes a lot into looking at the rates over time and looking at it regionally. But you know, we do look at it for several cancer types and over different race and ethnicity and sex. But sometimes too, just depending on how the counts and of these cases are, they can be small and they're not often displayed. But overall, we are still looking at a period, the full period.
And you're comparing Scott County to the statewide rate.
Yes.
I think it would be really helpful for us to know county by county actually how to compare. If that's possible, I think that would be really helpful for us to know.
Okay, I think we're going to try to get a couple of questions online. If we could get your question next, then we'll get a couple online first, and then we'll get to yours last, okay? Thank you. So we do have a question from the audience about the survey. The survey was not sent in the mail or any other way through social media. How was it shared equitably for those who do not use social media? So when the concern came about, and I'll speak for Sydney, our local deputy, she worked really hard on this. Not responding to the survey does not mean that the information was not provided to the cancer registry. It was just an easy way to try to have the community connect and complete this information and be able to have the local health district assist with completing the information. The information is reported regardless to the cancer registry, and they will get it. But it was more of a, let's support the community and make it a little easier for them to get this information out. But regardless of the survey and your ability to complete it, that information still gets to the cancer registry. So I have another question, and this would go to Rebecca. What kind of data would suggest that air quality is worth exploring? And there's some concerns noted regarding chemical plants in the general area.
Thank you for the question, and it's kind of similar to, I think the question we got earlier about whether air quality data was evaluated. We would have to explore that specifically through our literature review and lean on assistance from our Department of Environmental Quality and Toxicology. We were to explore that further. We have not at this time.
And thank you for that answer. And our last question from online, and then we'll get the gentleman who was in line. At the current time, we're not seeing a cancer cluster. Moving forward, you'll be observing and pulling 24 and 25-year data. However, what are we seeing? What exactly is the data saying? Is there concern that if this trend continues, that it will be considered a cluster after the 24-25 data is collected? And has there been any indication that there's a genetic component to this? Does the data support any type of direction towards cancer? I know that's a lot of stuff. Sorry.
Okay, I will answer that as best as I can. Well, for the 24 and 25, again, we are incomplete for those years, and we're reaching a 90% complete for 2024, but without that, we can't do a reliable investigation to determine those rates for those years, which is why we require that full year information. So we'll just, as we recommended, we will continue to monitor those 2024 and 2025 cases as we receive them, so that we can ensure that we are capturing these cases.
Thank you, and then we'll take our last question from the judge.
I just had one as well. I'll wait for mine.
So again, we do have to follow those CDC guidelines, and we do have to verify the diagnoses, the cases, and all of those things. So, you know, not necessarily, I guess is the short answer, but we do have to take those additional steps to ensure that we have the right cases, that we have the right cancer types. We do have trained registry staff to be able to understand what specific cancer types so that we can group them and then and use our literature review to be able to see if it's feasible to also group additional classes together to explore that. So we can't necessarily say that if we're seeing this, but that's a cluster. Perhaps as well kind of follow those steps and have that full year information. So let's just say that all these are. We would have to calculate the statistical analysis to be able to say that, and then after that, you know, if the data would point to that, then we would also look at designing a study to then look at what potential exposures. So kind of going back to what I mentioned earlier, there it's possible that there could be a cancer cluster that may cause, and then it's very rare found that there are causes. So we still have to go through those steps to really identify whether or not there is a cluster. So let's just say we would do all those vaccinations. If meeting all of the criteria, then we would follow the steps to then do a more